Yes, I showed you that the eyes could affect the strength, the production through the arm.
So could you tell us a little bit more?
Oh, again, you have, our conversation with the brain is based on muscle testing. It is our kind of response from the CNS to provocation. We provoke the brain with different modalities. That's our job. We provoke the brain with different modalities and we see how it responds. And the only way it can say, I like something, is to stay strong or get stronger if it was weak. And the way it says I don't like something is to stay weak or get weak if it was strong. Yes. Especially when you actually have a physical or a chemical input that includes some dynamic change. So when we use the eyes and the eyes move, it should not affect our strength output. So if it does, there is a problem with the eye movement and how it is influencing the brain's processing function. And the brain goes, I don't like to look that way. And you get a response in the system, a temporary inhibition. So we can use this for all our assessments. This is how we assess different systems. We can assess the musculoskeletal system. We can assess the vestibular system. We can assess vision systems by provoking these systems and seeing what is the capacity, what is the tolerance to that provocation, and if it is distasteful or pleasant or positive, negative or positive for the brain. So that is what you do. So instead of guessing, or relying on the patient to tell you what they think about something, you need to have something that short tracks directly to the brain. Say, do you like this or not? Because it's like a massage. It might not work at all, but the patient goes, I really enjoyed that. But it didn't fix the problem. Yeah, it goes, it's a great massage. It did what it should do. It made you feel relaxed, but it didn't fix the problem. So it is the same thing where we need to say to us, the brain, directly, is this an advantageous intervention or not? Irrespective of how it was perceived by the person emotionally. So that is why we can use the muscle test response as a kind of question-answer, binary question-answer in terms of yes, no, or indifferent, yes, no, or indifferent.
Can you talk a little bit about when we're clearing the cervical spine, why some people have a response in different positions of the neck? Like, do you think is there a biomechanical component? Do you think it's like a nerve tension type? Because in actuality, it shouldn't change, right? That would be a normal, that would be like status quo, that's normal, right? But for the people that have changes in strength, can you talk a bit more about that?
The problem with the tissues as they are in the living entities that it is so complex. And therefore, we see a history of simple explanations of discoveries about the human body that were very straightforward. And you can see that in the early rehab approaches, we had very simple biomechanical isolated explanations for the results we got. So as time has come on, we see that the factors that go into a response are much more complex and unknown than we could ever have imagined. And you see now that concepts such as the importance of the psoas muscle has died away because it's just not that important anymore to have one single tissue claim primacy over the others as the one that really screws you up or really helps you do something. So you can see we did taping of the knee with McConnell for a while, and we thought, oh my God, if you could just learn McConnell, you can get rid of knee pain. Then somebody says, well, what if it's coming from the hip? And Gary Gray says, what if it's coming from the foot? And everybody was like, oh my God, can you imagine? The knee pain might be coming from the foot. Try touching that. So then went on, and then people said, what about the fascia? You go, oh no, it couldn't be. And then somebody said, oh my God, it's the fascia. So if you go by that concept, when you treat somebody, you might as well flip a coin and go, what is that? What am I actually doing? So when I started teaching, I said, don't try to define this, because Levitt had warned us years ago when he lectured. He said, do not get into arguments about the mechanics of what you are doing. You will fail in the argument because we do not know enough to claim knowledge about that. And if you try to defend manual therapy through biomechanics, you will fail. And that was his message to us. So I do not try to defend the result through biomechanical rules because they are limited to certain structures, very much so. So if I name the facet, I have to have research that says the facet has primacy in responding that makes you get better. So how many tissues can I then name? Yes, so that is why we can only claim to say that the input that we have used as an intervention has had a positive response from the central nervous system. And that's about the end of it. Because if you dare to start hanging it on a tissue, you could end up, no one will believe you. Science will not back you up that far because we just don't know enough. I hope that answers the question. So we are slaves often to the idea that there is a particular structure that we must affect to get a response. And if we do that, then we are again slaves to technique. And that's it. Yeah. We are limited by that. And as you can see, to be effective within the rehab world, you must be a jack of all trades and master of none. Yes.
For the canister treatment back from the first course.
We can't hear.
Oh, for the canister treatment back in the first course.
What if the patient can be prone to,
If the patient cannot do probe,
to check the system?
oh, you can do it in supine.
Okay.
Yes, you can do. You like the blocking.
The blocking.
Yes, you can do some of it supine. You can do it supine. I did it prone because I think it was easier at the time. But there's no reason why I'm trying to think. There's no reason why you can't do it supine. I'll go through it in my head, but I think it can be done. And some people do it supine as far as I know. I know some chiropractors who do the blocking supine, so it is possible to do. Yeah, I mean, when you have somebody pregnant, you can't do it, but, and they are limited by that function. Yeah.
How will you be able to do counter rotation and rotation?
You will have to place the roll or the towel on the sacrum and push the crests back and vice versa. So it might be, not all of them will translate as efficiently, but you can still do most of it supine. Yes?
So if we get, we go back to the shoulder and the balance coactivation,
Yeah.
the roll.
Yeah.
So I just want to be clear. So I understand what you're saying about the biceps attachment, top
Mhm.
triceps, and the water, and controlling that movement. The lats would be trying to pull the humerus into extension, the pecs are going into the horizontal adduction. The function of the serratus normally is to protract. Are we pulling the ribs as you're doing that roll? Are you getting that, the ribs pulling posteriorly
Yes.
at that time?
Yes. Once the job of the serratus is to pull the rib cage back as you roll on the scapula. Otherwise, you would not be able to do that. The serratus pulls the rib cage back and flares the ribs posterior. That's its job. Yes. Yes. Concentrically. Yes. Because the rib cage is attached here to the medial scapula. As these two shorten, the rib goes back towards the medial border. That's the concentric. Yeah. So this it does, and it spreads the back. And that is what its job is. So that is why it is important to understand that the motor program for that is not the same as this. Yes. And therefore you cannot replace one with the other. That is why no amount of this reaching is going to translate to an improvement in this. With the caveat is that you can strengthen the serratus this way, but you have to train the function in the modality that is required. Closed chain or open chain. Any exercise can strengthen a muscle, but it doesn't give it function. Yeah.
One other thing that, you know, as I kind of gotten into this DNS stuff more and more, getting somebody in prone 3 months, and the trying to get them to isolate the scapula. I wish maybe sometimes they could just talk about the points, because I noticed that you're pointing to the medial border, trying to facilitate. It's like there's always too much use of the upper tract, the pec. You know, you see the teres major lighten up. You know?
Yeah. I think that there are problems. We discussed a little bit of this yesterday. First of all, the 3-month position that we often quote is a voyager position, which is not a 3-month position. Let me be quite honest with you. The 3-month position of the baby.
Hold on, I don't record you saying this. I'm gonna send it.
You can
Fired!
The voyager position that we call 3 months is very low, and the elbows are at the auditory meatus. Yes? The baby's 3-month position is this. Yes? The elbow is under the shoulder. This is 3-month position in actuality. So when you take somebody who has an impingement syndrome and you try to get them there, or they have a brachial plexus tightness, and you try to get them there, the shoulder will stay up because by now it's being stretched. They don't have this position available to them. So it means that if you cannot start here, don't start here. You have everything from first month, second, third to work with before you get to this position.
That's interesting.
Yeah.
Any aspect
No one's ever
of
said
the
that.
range of maybe
No one's ever said that.
No one's ever said
No one's ever said that, first of all.
We got 2 Italians back there.
I've been putting them back before, and then in my head I'm saying, I hope no one knows DNS so they don't think they're because I feel like I'm cheating, but now I know I'm not. So.
No, you're not. The first month position is this, yes?
Yeah.
Yeah. And somehow you have to get from here to there. Yeah. So there must be positions between that and this that are usable. Otherwise, how did the baby get there? The baby does not go one way here and then it goes like that. But in order to make it, but our limbs are so long that you cannot put an adult in the, because it's impossible to stay there. So you need to have the first position taken into this. Yes. Now my knees don't push my face into the floor, and I can now use this position to get the scapula in on the thorax. But you must keep in mind that the support point is not at the elbow. The elbow belongs to 3 months. The forearm belongs to second. So here is the support point for this position.
Yeah.
And this is the support point for this position. So you have to work with this position, and by understanding what tissues are causing this. Is it brachial plexus, nerve, or is it contracture? You will then work on the tissue involved until the patient feels that this is available to them.
So kind of like a test retest.
That's right. And so by looking at, we have the test where you must abduct your arm to 100 without the scapula chasing you. If you are moving that earlier, then you have a contracture or a restriction. So you must now find out, is the restriction in the tissue, or does the patient feel tension in the nerve and goes, my elbow, I feel tingling, I feel something going down to my finger. Then you will work on the appropriate tissue to get it there. And again, that is why it is important that the shoulder is depressed at the medial border and not at the lateral border, because that will impinge you. So the latissimus cannot be used to pull the shoulder down, because it will pull everything down and downward rotate the scapula against the very movement you're trying to go. Yes, to do. So those are the challenges of getting into 3-month position modified, and we usually have to back away from this because this position that we call 3-month is almost a 6 or 7-month position. The elbows do not come this far forward until you're much older. Yeah. But the thing is that we have taken this position from Voiter. This is a composite position.
Switch elbows.
Oh yeah, we have taken, because I'm talking, this position from Voiter, and we say, well, when you want double support, bring this one up. But it's not a 3-month position, it's a double support position, but it's for an older child. It really is. So it's really, 3-month does not exist out here. 3-month exists here. And this is part of Voiter positioning, which is a position taken from different months. It does not exist in reality. But each component of it exists in reality, but not at the same age. Yes. That's the thing. Yes, you go. But
Depending off of that though, if you were to take a child and put them into the voice position, despite that's not for their development, you can still get positive.
yes, you will. Yes, because the components belong to the global movement pattern. And the child is Gumby. It just doesn't go to those positions voluntarily because it doesn't have the strength or the ability to get there on its own. But that doesn't mean you can't put it in a position. You can. Yeah.
you said about which area of the glenohumeral joint should be depressed.
The middle bone.
Of the scapulothoracic. Oh, yeah. The scapula should be externally rotated. Yes. So the medial border must depress, and you must have a slight this kind of angle, not this, and definitely not this. Yes. You want to slide this angle if you can get it. And then the humeral head
Nice work.
cannot be, well,
It's nice work if you can get it.
if you can get it. The humeral head must be pulled down as it rotates upwards. So that's what I was saying, that teres minor and major have an important activation role to pull that humeral head down. And if it doesn't do it, the deltoid will pull it up and jam.
And you're saying sometimes the lat works too hard.
Yes, because the lat is attached to the
Right.
arm and sometimes the inferior border of the scapula. If you activate it, it'll downward
It'll pull
rotate.
the
Yeah,
whole
downward
I think,
rotate.
I think we can see the same as like a bicep and tricep between the levator scapula and the lat.
That's right. Yeah, that's
Okay,
right.
because
yeah.
when we are like raising,
Mhm.
the levator scapula needs to
Length.
length,
Yeah,
okay?
Yes.
yeah.
And there's the same, if it's like too tight and this is too tight
You can't. You
It
can't
will, like,
rotate it.
for like
It
the
will
other
downward
position,
rotate,
downward.
hold it in that position. So that is what you need, eccentric of the lat and eccentric of the levator as coupling to allow the scapula to rotate, whilst the upper trap, lower mid trap, serratus
Reticenter.
turn that wheel of the scapula like that.
So manual therapy then, if you're seeing that that the lats are overactive, do you try to do you both facilitate teres and try to like stretch lat and levators? I guess what do you?
Yeah, I get you what you're saying. When you see that, you must make sure you have, you must first of all find out what length you have of the levator and the lats. Are they tight? Because if they're tight, you're going to have to release them somewhat. And then you're going to use reciprocal inhibition of the other muscles, the serratus, the lower mid trap, the upper trap, to cause this so that this will lengthen and this will lengthen. Yes? So if these ones are active, these ones must lengthen to let this rotation happen. So anything you can do to improve that function now becomes important. And so the primary inhibitor of those would be the serratus, because it has this function, pulling the scapula down and out and forward like this. That's its job. So you have to do it. And the lower trap, of course, must do this. So if you can get those two to work, they usually start inhibiting this. Sometimes people...
You're saying if we can get those to work, they'll start.
the trap and the serratus to do this job, they will inhibit the
Okay.
levator. And the problem is that many people, for some odd reason, try to train their lats a lot. And somehow they think it's a stabilizer of the scapula. It really isn't. It assists, but it is not a stabilizer of the scapula. So I don't know, they try to pack it down to do stuff. That goes with downward rotation, so good luck. I don't know why they try to do that, but they do. So I remember I had a patient come to me, she goes, yeah, I'm doing CrossFit and, I just can't lift it. So they keep on telling me to pull my lats down. And can you help me do that? I go, I wouldn't do it that by you. She was like, what? I go, I wouldn't. There must be something else going on, but I would not use your lats to substitute for something else in your shoulder. And many times, it is the rotator cuff that is incompetent, and therefore the other muscles go, oh, this one we can't touch because it's not stable. So the person is fighting but it's the rotator cuff that makes them unable to complete the movement. But all the trainers go, oh, it's the big muscle that is not doing a good job. You need the big muscle to help you get that up or hold this down whilst you arm this up. It's not like that. Many times the big muscles just refuse to participate if they know that the smaller stabilizers are not confident, because you're going to destroy the joint. You're going to destroy the joint. They're so powerful that they will destroy the joint. And your body's always trying to protect those tissues from damage. Body doesn't mind pain, as you can see. I have this wonderful, wonderful video, I must pull it up. It's a PT who's treated her husband for knee pain. I'll post it. It's ridiculously not funny. But it's a professional attempt at rehab. So that's what I'd say. Okay. Anything else? That's all, folks. Okay.